this is your brain on drugs, and this is Punk Rock Psychiatrist. Today, what I'm going to be covering are depression subtypes. So, I'm going to cram this in. There are many subtypes of depression, and there's some research out there to suggest that you might want to pick some antidepressants over others in these treatments. So, if you didn't really consider these different subtypes, you'd probably land on the right treatment at some point. If you listen to all the episodes, if you listen, when I go over kind of the algorithm, the STAR-D trial, if you kind of go through those steps, if you use the augmentation strategies that we discussed in the previous episode, you're probably going to land on it. There's not going to be any new treatments in today's lesson, but you might learn that you would pick one treatment first that maybe you would not have otherwise done so because of the subtype. So we're going to talk about all the subtypes. I'm going to define them, and I'm going to go through what treatments that we might want to pick first, second, third, etc. So I could probably make all these into one episode, each one of these into a separate episode, but this is mainly a drug podcast, so I mainly just want to highlight what the different subtypes are and what the drug considerations that you might make. All right, so let's go ahead and go down the list of what subtypes I'm going to discuss today. The first one, treatment-resistant depression. Next, psychotic depression. Then depression with mixed features, depression with anxious distress, melancholic depression, atypical depression, seasonal pattern, that's seasonal affective disorder. And then the last two I'm not going to talk about today. So catatonia, I'm going to go into more detail in that when I cover antipsychotics and schizophrenia. But you can get catatonia with just about anything. Different medical disorders. It's not just from psychiatric disorders. Schizophrenia is one of the ones that we think about the most, but of course you can get catatonia with depression as well. So that topic will be covered. It'll probably be like a year or so before I get around to that. But just to kind of bring it up, catatonia is a subtype. It does have other treatments, and just kind of briefly throw them out there. Benzos, high doses, increasing doses until the catatonia goes away, and ECT. Those are the two big ones. But like I said, I'll go into more detail on that later. And then the last one, peri-partum onset. I'm going to have a whole series of stuff on what is kind of called reproductive psychiatry. So all the different female life cycle differences in depressive disorders. I'm going to cover those in a separate topic. So hold on. That'll be probably a few episodes from now. For the we'll talk about peri-partum onset as well as others related to that. But today I'm going to go over those ones that I listed previously. All right. So the first one, treatment-resistant depression. All right. I think we're all probably familiar with this term. You're kind of thinking, oh, this is a type of depression that we've tried to treat and the patient's not getting better. But it actually has a specific definition. So the specific definition is 4 unsuccessful trials of medication of adequate dosage and duration. All right. So if they didn't tolerate it, that's not a trial. If they didn't take it long enough, that's not a trial. If they didn't get to a therapeutic dose, that's not a trial. Okay. So you've basically started them on something, you've got to a good dosage, and they've been on it long enough, and we've done 4 of those. That's treatment. That is the definition of treatment-resistant depression. I'd probably start thinking this after like 3 trials, but formal definition is 4. All right. Now, if you remember when we talked about kind of STAR-D and like, they went through 5 different treatments there, and they got 67% of patients better. So these are patients essentially that went through kind of that algorithm, went through about that number of treatment, and they're those leftover 1/3 of patients. All right. So it's actually a lot, right? So this is about 30% of patients diagnosed with MDD. And there's actually, interestingly, been an exponential increase in this since 1980. And I had heard that in a lecture somewhere, but I can't exactly remember what their reasoning was for that. But it's on the rise. I think it was someone who talked about psychodynamic therapy, and they were, maybe it was there. There was less psychodynamic therapy going on, and more of a switch to meds. And maybe their theory was that the psychodynamic therapy is actually like super helpful, and because of time restraints and limited resources, we're not able to use it as much. I mean, but for my personal research, I wouldn't say that it's like that much more effective than meds. But at the same time, if a patient has a lot of treatment, they have a lot of time with a provider, and they're getting meds, they're probably a little bit more likely to get better. All right. So the downside here for you, if you're a psychiatrist, but if you're primary care, not so much, is that they make up a large proportion of the psychiatry panel, right? So these are folks that, I mean, and this is like mostly what we're seeing, of our depressed patients. Most psychiatrists are seeing schizophrenia, bipolar disorder, and they're seeing treatment-resistant depression. And they're specifically seeing the treatment-resistant type because primary care is doing the job of running them through those couple of trials before they come and see us. Maybe not 4 trials. I mean, I would typically consider that if you're a PCM, you should try a patient on a couple of meds, and if you're not getting anywhere, send them our way. So, I often get frustrated that, man, I'm just not having much luck getting depression treated here, and one reason for that is, and you can also often think from that, man, these meds just don't work that good. Well, a lot of the patients are on these meds and doing great, but they got it from their primary care. And so, as a psychiatrist, I may have a little bit more of a skewed viewpoint that these medications are quite not as effective as the literature may suggest, because a lot of those patients that it does work for are the ones I'm not seeing. So primary care, you may be seeing you may have a skewed view the other way, like, oh, these meds work pretty good. I've seen a lot of successes. And then when I don't see one, I send them to psychiatry, and then I'm not really following them anymore. All right. So this is actually a big deal for us, for the psychiatry folks out there. And I forget who it was. I think it may have been I'm not sure. It may have been Dr. Mintz, that I'd mentioned before when we went through our efficacy talks, that there were the 6Ds. All right. So he had it like the 6Ds. And so I looked through these, and it's like, yeah, I pretty much follow this as well. And I like this categorization. So when you have a patient who is basically meeting the criteria for treatment-resistant depression, you want to kind of go, what are you going to do next? You're going to throw another antidepressant at them? I mean, ECT, what are we going to do here? Like, we should probably maybe reevaluate and go through the 6Ds, and let's take a look at those. So first, diagnosis. Is this even major depression, right? Have we diagnosed this patient appropriately? Might this be PTSD or personality disorder, adjustment disorder, some sort of social problems or relationship problems, a sleep apnea, a medical issue, and a whole host. I'll probably have a whole episode on all the medical issues that it could possibly be. Is this a thyroid issue? Is there some sort of tumor or cancer? I mean, who knows? There are like 50 things that could be causing depression that's not major depressive disorder. So if the antidepressants aren't working, maybe we should, book a longer appointment time for the patient and go through a really good detailed history, lab workup, see if we can ferret out something else that might be going on. Because this, the fact that these aren't working may mean that this just isn't major depression. Okay. Next, dose. I see this all the time. Max it, right? I've talked about this before. Just because if someone gets to 100 milligrams of sertraline, and go up, the max dose is 200. Now, you may not be able to because of tolerance issues, but I see a lot of patients that come to me and they've been on like a mediocre dose of a med for a long period of time and not doing better, tolerating it fine. And sometimes patients may not tolerate it earlier, but as they've been on it for several months, they can tolerate it. And so let's max out, like remember what I said before, they need to be on an adequate dose and duration. If we haven't maxed that out, and the other thing, a lot of things out there say, you don't need the max dose. They should be able to respond to a lower dose. Now, there may be CYP enzyme stuff going on. They may be a a fast metabolizer. They may need a higher dose. This is where you could consider getting a psychogenomic test. But like as I mentioned before, why not just max the dose out? Why do I need to get the test? I had heard recently that maybe some patients might feel more comfortable if they see the test and it's like, oh, I'm doing what the test says. But I kind of think this test is a waste of money. But yeah, lots of reasons why the dose they're on may not be helping. So let's max it out if we can before we. And you may look at their history and they've taken several meds, but they haven't maxed any of them out. All right, which one did they tolerate the best? Let's try that one again. Let's crank it up. All right, next D, duration. Remember I mentioned above. I mean, the definition. Like, did they only take it for a month? Did they miss 2 doses a week? Right? Are they taking the med and are they taking it for a long enough time? I mean, it can take up to 3 months for these medications to work. And if we switch, that could fall within that time period. But like typically, if they're coming to you for treatment-resistant depression, they've probably been on treatment for the right duration. But I mean, I would check with adherence. Like, did they actually take it every day? Did they actually take an adequate dose? Were they actually taking it every day? Did they quit after a month and then start a new med and then another month and start a new med? Like, have we really had the right duration that we need at the right dose? Right. So let's make sure that's going on. Next D, the drug mechanism. Try drugs with different mechanisms. Are those 4 drugs that they've tried all SSRIs? Or are they like 2 SSRIs and 2 SNRIs? Let's not do that, right? I mean, you can do 2 SSRIs, right? Like that's perfectly fine, especially if it's a tolerance issue. With one, hey, let's try a different one then see if that works. But if we're talking about treatment-resistant depression, and we're talking about, hey, what are we going to do next? Let's give up, or what's going on? Should we go to something different? Have they tried enough mechanisms of action, right? So I'd like to see 4 unsuccessful trials of 4 treatments that are of different mechanisms. An SSRI, an NDRI, maybe an NMDA receptor antagonist in there, a TCA, an MAOi. We've talked about all these. Thyroid, lithium, right? Lamotrigine. Go back to the augmentation. I went through all these different treatments. Have they tried 4 different mechanisms? If not, if they've only tried a couple, well then let's throw one. Let's finish that treatment out first. Make sure we do that. All right. 5th D, different treatment. So that's kind of similar to drug mechanism, but it's a different class of meds or ECT, right? So have they tried ketamine? Have they tried ECT? Have they tried TMS? Right? So not necessarily just the drug treatment, but different treatments in general. Have they tried psychotherapy? Have they tried, bright light stimulation? I mean, there's lots of different things that we could do here. So if we're not having luck with lots of different meds, let's go for a different type of treatment. Maybe a supplemental. I haven't got to these yet. Maybe I should, I'm putting those at the end of the depression series. I'm going to go through all the supplements and complementary treatments, vitamins, etc., that they could try. I'm going to go over the procedures like ECT and so forth, right? So if they've tried all the meds, let's try one of those, okay? And then the 6th one's dynamics. So if you go back to the efficacy lecture, I talk about psychodynamic therapy treatments with the treatment of medications and how like using psychodynamic techniques during prescribing can work. So go back and hit up, I don't remember if it was efficacy episode 1, 2, or 3. It definitely wasn't 3, it was 1 or 2. So I highly recommend those episodes that I'm going to tell you all about how to like max out and the efficacy of our meds and treatments. So maybe using some of those dynamic techniques. They're not necessarily psychodynamic therapy, but the dynamic techniques. So Those would be the 6 approaches that I would have when looking at a treatment-resistant depression patient. I'm going to go ahead and tell you what the FDA-approved treatments are, right? So, and we've talked about all these before, but these are the FDA-approved treatments for treatment-resistant depression. All right, most of them are antipsychotics: aripiprazole, brexpiprazole, olanzapine, quetiapine, and then we've got S-ketamine, which is Spravato, that's the nasal spray, ECT, and RTMS. Okay, so those are actually the FDA approved treatments for treatment resistant depression. As I mentioned, you could do different things other than this, but these are the ones that have FDA approval. What are some off label treatments? We've mentioned these before: lithium, MAOIs, TCAs, pramipexole, and then a couple I haven't talked about: vagus nerve stimulation and deep brain stimulation. I don't know how often these are used. I've never seen it, never heard of it, don't know anyone that does it. I think it might be out there. I'm not sure who's doing it and for what patients, but those are a couple other treatments that you could use for treatment resistant depression. So it's a long list. And if you go back to the augmentation lecture, there's a lot more. And then there's a lot more in future episodes I'm going to talk about. We've got lots of treatments for depression. Okay. So those are all the things you could do for treatment resistant depression. Let's talk about the next subtype: psychotic depression. All right. So we've talked about in the augmentation, I briefly mentioned that antipsychotics are an augmenting agent that can be used as an adjunct with an antidepressant, or they could be used in depression with psychotic features. That's what we're talking about today, or right now. So psychotic depression, major depressive episode accompanied by psychotic symptoms, which are hallucinations or delusions. So if you've got major depressive episode, you've got hallucinations, delusions, that's psychotic depression. Psychosis is present in 15 to 20% of patients with major depressive disorder. That number sounds high to me, but it's the one I found. It's not my experience that I've seen that huge of a percent, but it's not uncommon. Okay. Now, note, psychotic symptoms can actually be secondary to lots of conditions. And this is one of those things that makes psychiatry so difficult and so, challenging for everyone. Just because you see psychotic symptoms doesn't mean they have schizophrenia. I cannot tell you how many patients I have seen with the diagnosis of schizophrenia that did not have it, but they had psychotic symptoms. Psychotic symptoms does not equal schizophrenia. It does not equal schizophrenia. You can have psychotic symptoms with bipolar disorder, with PTSD, anxiety, personality disorders, medical disorders, depression, and you can see it in mild, moderate, and severe types. I think most of us, think, oh, they've got major depressive disorder severe with psychotic symptoms. You could have mild depression with psychotic symptoms. Just because their depression is not that severe doesn't mean they can't have psychotic symptoms. And that may make you think, well, is this a schizophrenia or is this a MDD mild with psychotic features? That's hard. I mean, I think my general teaching was, what came first? Was it the mania that came first and the psychosis came later? Was depression came first, psychosis came later, or psychosis came first? But at the same time, like, how do you know? You weren't there. You don't know what came before. This patient, if they have psychotic features, is likely to be a poor historian. So don't just label everyone with schizophrenia. It's lazy, and so many people are doing it out there. I had a patient. He had he had psychotic symptoms. In the military. He saw, for whatever reason, he got sent out in the community and not to one of the military providers, and the person he saw diagnosed him with schizophrenia day one. First of all, that's ridiculous. Even the DSM says you have to have symptoms for 6 months. And it's like, what did they say? Oh, you've had these symptoms for 6 months, but I'm seeing you for the first time today. No, thank you. Don't do that. I want to follow this person. I don't want to see them and find out, oh, you've had a history of this for 6 months, but you've seen no one in that time. You haven't had a psychotic disorder diagnosis. You haven't had a um, the I forget the name of it, but the diagnosis that you give for like between 1 and 6 months. psychotic symptoms before you give schizophrenia. There's a reason why we do that. We do that because we don't want to label someone with schizophrenia that doesn't have it. This could be a million other things. Like I said, psychosis can be caused by so many different disorders, many medical disorders. You can get it. This patient, when I talked to him, I diagnosed him with PTSD. And like I said, when he saw that provider on the outside, not only did they diagnose him day one, but they started him on a long-acting injectable antipsychotic on day one. That's insane to me. Like, if you're going to use an antipsychotic, you at least want to try the oral first and see how they tolerate it before you give them a long-acting. That's just bad practice. Don't do that. I mean, on the other hand, we're not using the long actings enough, but like, don't just go straight to it on day one. Just like, don't go straight to a diagnosis of schizophrenia on day one. I had another patient was admitted to inpatient in my hospital, given a diagnosis of schizophrenia. I was not buying it. It just did not fit for many reasons. I was suspicious of some sort of personality stuff. We did psychological testing. They confirmed my diagnosis. She had, I think she had like a dependent personality disorder or something like that. I mean, and you're probably thinking, oh, was she cluster A? Did she have like a paranoid type or a schizotypal type? No, it was actually dependent. And she so you can have psychotic symptoms with all these other diagnoses. So first, get that right. And if it's a depression disorder with psychotic features, let's treat the depression disorder with an antidepressant regimen. If it were PTSD, let's go the PTSD route. If it's bipolar disorder, go the bipolar route, right? So you need to get the primary disorder correct first. And you may not get that first, but come back. This is why on the previous slide I said with the treatment resistance, the first D is diagnosis. Get the diagnosis right? So we need to correctly identify the diagnosis to get the correct treatment. If it's depression, let's treat it like depression. Okay. And I think I mentioned it. So the last one was depression, mild, moderate, severe. And then there's one more, the healthy population without any disorder. I think it's like 20% of the population that has hallucinations at some point in their lifetime. It's super common. Just because somebody has it doesn't mean they have schizophrenia. All right. So getting that out of the way, we've now decided that this is psychotic depression. What do we do about it? First line, you guessed it, antidepressant. Definitely, I mean, this is a primary depressive disorder. I would go to antidepressant first. If they were really, really bad and they were like admitted to a inpatient unit, I'd probably add an antipsychotic on top of it. However, if that's not the case, I'm going to try and get away with just an antidepressant alone, monotherapy first. I've heard that SNRI may be preferred over SSRI. You wouldn't be wrong to do either one. And then if that's not effective, I've got a list of 5 treatments in order that I would try. First line, antipsychotic. So now we're talking about augmenting. We've already talked about these augmenting agents, right? But specifically for psychotic depression, what are we going to do? First line, antipsychotic. We're going to talk about that in detail after I give you the list of 5. Second line, ECT. This one is so massive. And this percentage here is like out of this world. 95% remission. You heard me. 95% remission of psychotic depression with ECT. 83% remission for non-psychotic depression. This could be your first line. I'm not a huge fan of the antipsychotics for this, as you're going to find out why on the next slide. If you've got ECT available to you, then it may be a good option. Now, it may be a perfectly good option to go with something else, but ECT is a lot more available than you think it is, and it's used a lot more than you think it is. I'm going to have a whole lecture on ECT later, but just throwing it out there, 95% remission. Boom, that's huge. All right, third line, bupropion, and I've seen this specifically mentioned for males only. I don't know that I would really care. Fourth line, lithium. Fifth line, ketamine. All right, those are the 5. We've talked about all this before, but let's dig deep on antipsychotics. Let's pick on antipsychotics. I love picking on antipsychotics. I hate me some quetiapine, right? I've talked about that before. Let's talk about antipsychotics for depression. Remember, as an adjunct for a severe depression or a treatment resistance, it's got a zero point 0.2 effect size. Not great. These drugs, we've already talked about the side effects that we get with antidepressants and how they're kind of unpleasant, nasty things, but not dangerous, not super bad. Antidepressants, not the case. Nasty side effects. Okay, a lot more poorly tolerated. More, I love them. If you got to use them, you got to use them. If that's what keeps this person functioning and sane and everything together, heck yeah, antidepressants, right? But if we don't need them, don't throw them in there. These are like a only if we need them. Like serious, we need to think seriously about this. Okay, so and let's explain why. So antipsychotic with or without antidepressants. As we talked about, if it's an adjunct, um, if it's for depression only, it's only as an adjunct. But if we've got a psychotic depression, you can use it as monotherapy. All antipsychotics have similar efficacy, so choose based on tolerability. All right. Now, when we talked about as an adjunct, there's some in the last episode for augmentation. We talked about some of them have evidence, some of them don't. For psychotic depression, um, they all have pretty equal efficacy. All right. However, let's break this down. Now, in 2010, the APA guidelines recommended antipsychotic plus antidepressant as first line. And remember, I'm not doing that. I'm saying antidepressant only first line, unless it's a severe psychosis. However, in 2010, the recommendation was both at the same time. However, there was very little evidence to support this. I'm not sure how they were making these guidelines. I'm often frustrated with these guidelines because I see stuff missing that has pretty good evidence. And then I see stuff in there that doesn't have that great evidence. Makes me think that there's probably some political shenanigans going on. Hence why we're doing this podcast. We're trying to cut through any kind of biases. All right. So I say there was little evidence for this. Why do I say that? First study, small study, N of 18, placebo lacking study. All right. Not a good study. Second study, large p-value. Large p-value, that suggests statistical significance, not so much there. Thirdly, the third study concluded that antipsychotic monotherapy was not helpful. So the third study actually suggested that the antipsychotic didn't really add anything. So we have 3 studies that were poorly designed, poor statistics, poor outcomes, and then APA is making the recommendation. Now, I'm sure that they would have their argument against me, blah, 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 blah. I'm not buying it. Sorry. However, after 2010, we have had a couple more studies to give us a little bit better evidence for doing this. I mean, based in 2010, I'd probably be saying I wouldn't even do this. Maybe I'd try it. Why not? You don't know what to do. Try something. But since 2010, we have a little bit more evidence. There's been 2 larger randomized controlled trials that did show benefit for antipsychotic with antidepressant. One trial, sertraline plus olanzapine over antidepressant alone, showed benefit. Next, venlafaxine plus quetiapine over antidepressant alone. And then there's those 2 larger trials. And then there's also, since 2010, been some evidence for olanzapine plus fluoxetine, right, which we talked about in augmentation as well. All right, so we have a little bit more evidence to suggest this could be helpful. All right, but what we need to take into consideration is the use of antipsychotics can impair recovery to premorbid functioning, right? It can impair frontal lobe symptoms, leading to apathy, slowing, difficulty solving problems, dealing with interpersonal relations, multitasking, and taking initiative. So we use these not with a grain of salt, right? Like we really don't use them unless you got to use them. Don't keep them unless they're really doing something, because they can really cause some serious damage. All right. The patient can also become dependent, passive, and quiet, and may lose insight into those symptoms. And they may say that they're doing okay, but they actually have become that way. And now they're just stuck on these medications. All right. Um, Another better design study showed that amitriptyline worked as well alone as it did with perfenazine, which is a first generation antipsychotic. So essentially, amitriptyline alone worked as well as amitriptyline plus antipsychotic. All right. Venlafaxine trial showed no difference between imipramine, another TCA, and olanzapine plus venlafaxine. All right. So here we are again, two TCAs compared against venlafaxine with olanzapine, the antipsychotic. There was no difference with the one that included the antipsychotic. Antipsychotic monotherapy is not well studied, despite the recommendation that you can do it monotherapy. Not well studied. All studies done do not show a benefit for antipsychotic monotherapy over antipsychotic plus antidepressant. If an antipsychotic is used, then this is a thing to take into consideration. So you've decided to use the antipsychotic. If it's used, relapse is worse if it is stopped sooner than 6 months or withdrawn too quickly. So if you put them on it and it's helping and you want to take them off, give it at least 6 months and take it off slower. And I mean, unless there's a safety reason to do differently. If you're just like, okay, we want to take this off, maybe we don't need it, but we're pretty darn sure that it helped. Let's keep it on long enough and take it off slow. All right. If you're using antipsychotic, use the antipsychotic dose, not the antidepressant dose. In the augmentation episode, I talked about antidepressant doses of antipsychotics. But here we've got this is not just a severe depression that's not responding. We're talking about depression that has psychosis with it. So we want to use the antipsychotic doses. Now I realize I haven't talked about antipsychotics yet, but you all are pretty familiar with them. My plan is to maybe I'm probably going to do that before I do mood stabilizers because so many antipsychotics are used as mood stabilizers. So we'll probably talk about them. I may talk about ADHD before that because, it's more common. Primary care deals with that. But hold on to your seats. I will get to antipsychotics. I know that you probably really want to hear about antipsychotics, but I want to do depression its justice. We're going to go through everything you would ever need to know about depression. And we're about 3/4 through depression series, which is I'm calling season 1. All right. So that's my 2 cents on using antipsychotics and psychotic depression. It's something that, if we had really severe symptoms, I'm definitely going to do. If they're a little bit milder, I would go with antidepressant alone first. I would consider adding it, see how it goes. If it doesn't work, get rid of it. Definitely something you want to have in your armamentarium. But kind of consider the fact that it's probably not as effective as you think it may be. And so, and here's the problem: if you do go with both an antidepressant and antipsychotic at the same time, if the antipsychotic wasn't helpful, you're not going to know it, and then you're like, oh my gosh, they're better. I don't want to change anything, and it's like, maybe they don't need this, but I'm afraid to withdraw it now because they got better, right? So better to if we've got the time, do the antidepressant first, and then if they're better, considering a slow taper after 6 months would be a good idea, right? If they get better, like I said, if they get better, I would probably with this addition, I would probably try and lower it slowly. And if I notice the symptoms creeping back, I put the dose back. All right. If they seem to be tolerating it well as I slowly take it off, keep slowly taking it off and leave it that way. It's always better if patients don't need to be on a medication. I think we fall into this trap of, oh my gosh, they're stable and everything. I don't want to change anything. But all of our meds can cause long-term damage, and the antipsychotics are probably the highest on that list as far as the long-term damage they can cause to lots of different things, while still keeping in mind that they're life-saving and life-altering amazing treatments that we need for certain patients. But we certainly want to be careful not to use them in patients that don't really need them. And you may be afraid to take them off. I'm not. I do it all the time. I'm always taking stuff off. And have I had a few patients that became psychotic and were hospitalized after I tapered them off as something? There's been a couple. I can think of one. Um, That's the only one I can think of. But maybe there's a couple others. Maybe some slipped by after they saw me. But I've taken a lot of people off these. The PTSD guy, I took him off. The personality disorder girl, I took her off. They did fine. One guy, he had schizophrenia. I didn't like that he was on such high doses of olanzapine and Depakote, and I actually eventually got him onto clozapine, and he became stable for years. And so he had a lot of like he was better and his symptoms were controlled, but he was just like basically a lump on the couch um, with the olanzapine and the Depakote. And I tried to lower, he had seen someone outside the military. They had like floored it on both of those meds at once, and no one wanted to take him off, but he just like wasn't doing well. And I knew this was a guy with schizophrenia, but I slowly took, the doses down of those, tried to see if, his weight was really out of control. I mean, we're on two big weight gaining medications. He was not doing anything around the house. He had no life. I'm not even sure if he noticed it, but it was just eventually he got on clozapine, and he's still on clozapine, and it's been, oh man, like 10 years, and he's still on clozapine. I still know that he's on clozapine and doing well. And probably one of the biggest successes I ever had. And that's the one patient that I tried to go down on their meds and landed him back in the hospital, but in the end got him on a better drug, better functioning, better control of symptoms. So don't, if you're suspicious that maybe this isn't working, and maybe the patients uh, may not need what they're on, cautiously take it off. Like that's your job. Your job is not to sedate the heck out of this patient and make them so out of it that like the symptoms couldn't come back if they were there. We're trying to get people better, to enjoy their lives and be fulfilled as possible. You can have a perfectly functioning life with these severe mental illnesses, but a lot of people aren't, because they're not well managed, a lot because they're not adherent to meds, and a lot because they're over medicated. All right, so let's not over medicate our patients. The next subtype that I am going to discuss is depression with mixed features. So what is that? Right, mixed features, we're talking about both depressive and manic type symptoms. So this is the definition. This is an MDD with a mix of symptoms of mania or hypomania. You have to have, and this is according to DSM, right? Even though I hate DSM, I'm still following it because that's what studies do. That's what research shows, right? And that's what, so we can have common definitions that we can talk about, right? Am I following this hard and fast? Probably not. But let's know what the precise definition is. We're talking about at least 3 symptoms of mania or hypomania nearly every day during the last 2 weeks of a major depressive episode. So basically, you got both at the same time. All right. And this is not bipolar disorder 1 or 2, because we're talking about at least 3 symptoms. And for those, we need more symptoms. I think it's 5 symptoms. But yeah, so we don't quite have enough criteria to meet a bipolar diagnosis, a bipolar type diagnosis. And we're having those symptoms at the same time we're having a major depressive episode. So we have the definition of major depressive disorder met, but now we also have 3 manic hypomanic symptoms occurring there as well. At least that means we could have 4 as well. If we have more than that, we're probably going to call it bipolar disorder, right? You could kind of consider this to be a bipolar disorder, right? I forget who it was, but I think it's starts with a G. Dr. G, I think he might be at Harvard. He's done some interesting stuff with mood disorders, where he basically says that severe depression and bipolar disorder are one and the same disorder on a spectrum, and that he treats them all with lithium. So that's interesting to me, and so he would probably say that this is just a kind of fluffy diagnosis that fits into his spectrum, and he would treat it like he treated it like how we would treat a bipolar disorder. But he essentially is saying that major depression and bipolar disorder are one and the same disorder. right? They're like he calls it bipolar depression, which is like an older term that used to be in the old DSMs, but was thrown out for who knows why. They split the diagnosis for whatever reason in like the late 70s, early 80s. But like it's so arbitrary, right? And as I've already talked about, lithium great for great to use as an augmenting agent and for treatment resistant depression. And so you might want to put lithium higher on your list, right? So with that being said, if we've got a diagnosis of depression with mixed features, something that I might consider to be bipolar disorder, even though it doesn't meet the full DSM criteria, you're going to want to treat it somewhat like that. And the research shows that the first line treatment of lorazepam, a drug that I am a fan of, and a second line quetiapine, one that I'm not a fan of for psychosis, but for mood disorder, I think can be a pretty good choice. I talked about that in the augmenting lecture, was the last one we had. So would it be my second choice? Not sure, but it certainly wouldn't be a bad choice. But there are a lot of side effects about it, but certainly something that you would want to consider. Those are the only two that I think we have any like clear evidence to suggest. But there are other medications that may be effective but have not been studied. Okay, all you out there that like want to go into research, I already threw out one last time, Pendolol with an SSRI compared to Auvelity. Which one works better for getting symptoms controlled early? I'm going to throw a lot of these out there. Hopefully there's some budding medical students and psychiatry residents that want to go into research, and I'm planting some seeds. Here's something else that I would throw in there. Studying depression with mixed features, lithium, lamotrigine, I would probably be thinking about those pretty high on my list. I would probably, I would. The thing is, you're probably not going to want to give a patient like this an antidepressant because of the depression. I don't like giving antidepressants to bipolar patients. I don't like giving them even as an adjunct if I've got them on a mood stabilizer, which I know a lot of people do. I'm not a fan of it. There's not a lot of evidence it helps. There's evidence that can make things worse. I'd probably be thinking about lithium with a patient like this, but going with a second generation with lower side effect profile like a lorazepam is certainly a reasonable option. I think you probably couldn't go wrong with those four choices: lorazepam, quetiapine, lithium, lamotrigine. There's probably a few others that you may even want to consider, maybe even a carbamazepine or something thrown in there. But we'll talk about all those treatments for. We'll have a really long series on the mood stabilizing bipolar meds. All right. But just throwing that out there for now, depression mixed features. Next one, depression with anxious features, in the past and also sometimes now called anxious depression. All right. So kind of like the previous one, this is a mix of two disorders, right? You have to have, so you've got major depressive disorder, that diagnosis met. We have that. They also have at least two generalized anxiety disorder symptoms. If they have enough to meet the criteria for generalized anxiety disorder, then they have generalized anxiety disorder. But if they have less than that, and at least two, not just one, then we could call this a depression with anxious features or anxious depression. This is pretty common. The prevalence could be as high as 50 to 75% in those with major depressive disorder. Because, I mean, think about it. Who with depression doesn't have any anxiety symptoms? I mean, and you only need two for this. I mean, I think that criteria may be a bit too low. I would maybe want a few more, but this diagnosis, I mean, does it really matter? Let's talk about what treatments that we might do. We've got depression and anxiety together. And at the same time, it could be difficult to discern an anxiety disorder that triggers depression from depression that triggers anxiety, from basically this disorder, which is like both at the same time. And are those three things really different? Who knows? The treatments are pretty much the same. So I had read this, that they may respond, patients with this disorder may respond less well to the medication studies in STAR-D. However, you should still try them first. The SSRIs, buspirone, bupropion. I don't know why this would be the case. I mean, as we said, this is 50 to 75% of those with MDD. And as we know, those are the treatments that they respond to. And that's most patients. So I question that. I'm not sure where I heard that information. Um, I would still try those. For this disorder, I would essentially do exactly what we've already discussed. I would treat this basically like depression. But if you're not having any success there, there's a couple other things that you could consider. All right. So we did talk about in augmenting agents the use of benzodiazepines, right? This is a patient, you've got a resistant type patient. They're kind of looking like a depression with anxious features. Other things are not really working, or maybe they're helping a little bit. This is the kind of patient that you're going to want to consider doing that augmentation with benzodiazepines that we talked about in the last class, right? Alprazolam has the most evidence. I don't like it because I feel like it's the one that patients get the most addicted to. Like, I like it for short-term use, but I really don't like it for long-term use. The one thing to bring up about alprazolam, though, is it does have 5-HT1A activity, which is different um, than other benzodiazepines, and it's got a TCA-like molecular structure. So alprazolam has some configurations that kind of resemble an antidepressant. That makes it kind of a good choice. I like that mechanism that it has. I like that molecular structure. What I don't like is the rapidity of like how fast the onset um, is of relief and the short duration of relief. Those two factors often lead to dependence and withdrawal. And so, am I going to give alprazolam to a patient chronically? No. I mean, I have never done that, and I've seen it done, and I've seen the ill effects of it. So yeah, I probably would not do that. All right. Another one, esopiclone. So that is Lunesta. It's a non-benzodiazepine receptor agonist or something like that. It's a sedative hypnotic. It's used for sleep. It's hypnotic. It's kind of like Ambien, Zolpidem. But it does have some features that are a little bit different. I'm going to have an insomnia series. I'm going to talk more about it. I'm also going to bring it up in the anxiety lecture. It's got some stuff about it that's a little bit different than the other Z drugs. And it's something you could use for sleep. So that's something that might be helpful as well. Phenelzine, we've talked about that MAOi. So we had talked how that specifically may be uh, good for depression, or sorry, anxiety and depression. Back when I talked about the MAOIs, so I would certainly consider that. And then some of the atypical antipsychotics, so second generations quetiapine and aripiprazole, would be some others to consider. So, like I said, I would go with the standard treatments. And then if those aren't working or we need some augmentation, I'd be considering maybe benzodiazepines, acetylclone, maybe a switch to phenelzine, maybe addition of a antipsychotic. Okay. Next, melancholic depression. What is melancholic depression? Melancholic depression. All right. Specific definition we're going to talk about. It's more severe depressive symptoms than a typical MDD. So we're dealing with more severe. Um, and then anhedonia, which is difficulty taking pleasure in things, right? Or lack of reactivity to positive news and events. Those two are required, right? For a major depressive disorder, it's depressed mood or anhedonia. But with a melancholic depression, you either have to have anhedonia or they have a lack of reactivity to positive news. So good things are happening in their life and they just don't react to it. Okay, so those two are key. Those are one of those two is the most key things for melancholic depression. But then you also have to have at least 3 of the following symptoms. All right, and these are all depression symptoms, but these 3 in specifically have to be included if we're talking about melancholic depression: excessive guilt, psychomotor retardation. So not so much the agitation. This is more of a slow. Melancholy is like the old. I don't know if it's a Latin word or a Greek word for like basically for depression, right? And so this is like more of a like unreactive, doesn't take pleasure in things, slowed down, hard on themselves type of patient, right? So at least 3: excessive guilt, psychomotor retardation, not agitation, deep despair and worthlessness. Often guilt and worthlessness are the same symptom when we're looking at MDD, but when we're looking at melancholic, we can split those and say, do they have one or both? Interrupted sleep, and we're typically talking about early morning awakenings. They wake up early, can't go back to sleep. Significant loss of appetite, so not increased appetite, only loss, right? With major depressive, it can be one or the other, but melancholic, we're just looking at loss. And then a diurnal variation. That basically means different times of the day we have some changes. So mood and energy are worse in the morning, all right? So that, early morning awakenings, and they feel worse in the morning. Okay, so those are the symptoms of melancholic depression. Why do we care? Okay, well, they might want to pick a different treatment for these folks. First line is actually a TCA. I don't know how many people are doing TCA first line. I would probably give them an SSRI first line or bupropion. But if that's not working, TCA is probably lower on my list, like fourth, fifth line. If this is a person looking more like a melancholic depression, I might pop that up to second, third line. All right, and I might start it in the beginning at low dose if they are having this sleep problem, right? So they're having interrupted sleep. Maybe I'm adding something, and maybe I'm choosing a TCA. Maybe I'm choosing a doxepin or a disipramine or an amitriptyline. Amitriptyline less so because of the anticholinergic side effects. Maybe a nortriptyline. I'm going to pick one of the ones that I think will cause sedation, but also could in the future be turned into an antidepressant dose that has the most tolerable side effects. So listen to the TCA lecture if you want to learn more. So yeah, I might start a TCA with the other antidepressant at a low dose to try and treat the sleep, and then I may end up taking that antidepressant away, or that the typical antidepressant away, and cranking up the TCA I've already started, right? So that may be one way to, like, I know I said it was first line, but like the idea of starting a TCA first line is kind of something that we wouldn't really do because of side effect profiles. We want to go with the least side effect med first, and that's not going to be a TCA, but a low dose TCA for sleep is usually well tolerated, may be effective, and maybe a way to kind of introduce that into that first line with the thought that maybe we pop that up later. So like if I'm treating this type of patient with insomnia, maybe TCA is going to be my drug of choice for the insomnia symptoms. All right. Second line, SNRI or mirtazapine. So those are both norepinephrine kind of medications. That's more of an energy promoting thing. I don't know why bupropion's not on this list. Like most of those symptoms are things that I'd probably be thinking about bupropion. So this is like what the standard evidence kind of shows: TCA, SNRI or mirtazapine, and then third line TCA with lithium, T3 or ECT, right? So I would probably be giving this person bupropion, to be honest, because other than the lack of appetite and the sleep disturbance, I mean, bupropion may be a good option. Maybe you're adding a TCA with it, because the bupropion is also going to have that NRI activity, like the SNRI or the mirtazapine, which is the second line recommendation. So you don't have to follow this exactly. But remember when I talked about how you've got patients that are like not getting better and they're thinking things don't work and the meds don't work and stuff? It may be because you're not giving them the right med, and maybe the med that you've got fifth on your list, or maybe not. Maybe you're the kind of person that would never give someone a TCA. Well, this is for you folks out there that would never give someone a TCA, maybe move it up to third when it's got more melancholic depression. Maybe you're uncomfortable with it, but hey, when we're not getting any better, consider the TCA. For those of you that are more comfortable, hey, have it higher up in the list. All right, and then remember, third line TCA with lithium, or TCA with T3. We talked about both of those in the augmenting talk, and then ECT. ECT is always a good option for MDD. ECT is the most effective treatment that we have, bar none, for depression. Bar none, it's the best. And I know a lot of people are afraid of it for whatever reason. You shouldn't be. And you'll find out several lectures from now when I talk about it. But always keep ECT in the back of your mind. These patients tend to respond less well to therapy. All right. Now, I know, and just a word on that, a lot of people say, oh, therapy and meds are just as effective. Like, that's on average. Some patients are going to respond well to meds and not therapy, some to therapy and not meds, and some will respond best to both. This idea that like everyone will respond best to both is nonsense. Okay. Um, some will, right? And this is the type of person that the patient that maybe the therapy is going to be less helpful in. I mean, this is like a really organic stuff going on. They've got a lot of symptoms that like probably aren't going to respond all that well to therapy. You could give it a go, but this is a patient you're really thinking about meds for. All right. Moving on to our next subtype, atypical depression. What is an atypical depression? Well, these are the symptoms. Mood reactivity. So they have a very reactive mood. Like something good happens, and remember, melancholic, good thing happens, they don't care. They just feel down no matter what. With atypical depression, we've got mood reactivity. Think good thing happens, they really feel good. Bad thing happens, they feel really bad. And it's just like they're, that may appear, somewhat like a bipolar, or sorry, a borderline personality disorder. So that's certainly something you want to suss out, like which one is it, and consider both in there. But mood reactivity can be a symptom of both of those. And then you're going to want to see at least two of the following: hypersomnia, right? So with depression, usually it's poor sleep, but can be more sleep. With an atypical depression, it's more sleep. They sleep all the time. Hyperphagia, right? Usually it's loss of appetite. With this one, it's eating a lot. Leaden paralysis, right? That's where they just kind of feel like they can't move. It's very hard to move. They feel very heavy. Um, so this is a very slowed person, right? They're sleeping a lot, they're eating a lot, they're not moving around. And then lastly, interpersonal rejection sensitivity. So kind of like how they have the mood reactivity to bad news, they're very sensitive to being feelings of rejection. All right. So you need at least two of those four plus the mood reactivity to call it atypical depression. What might we do differently? These are patients where MAOIs and bupropion are the treatments of choice. Of course, I would go with bupropion first. I would probably not go with an MAOI, even second or third, but this is a patient that I would definitely, like a lot of patients, I never go with an MAOI. Maybe I should at some point. But these are symptoms that like MAOI definitely you need that on your list. It is something we reserve later, but it's something you should definitely be trying in a patient that has not responded to other things. Okay. And the last one I'm going to talk about is seasonal affective disorder. All right. This is not a separate diagnosis. I think it's listed in the DSM as MDD with seasonal pattern. And then you can either be like a fall winter onset type or a spring summer onset type, with fall winter onset type being the vast majority. All right. So what is the definition of this? And I've even heard that like a lot of people think that maybe this is not even really a separate diagnosis. It's hard to really determine. Um, we don't really know why it happens. It has something to do with light, circadian rhythm disturbance. I read something about retinal response with decreasing light and so forth. And some individuals are like more sensitive to that than others, and they're more likely to get this. There was also something interesting I saw about people in Iceland have actually a lot lower incidence of this compared to other countries that have really dark winters, and that there was some sort of study that showed that those of Icelandic descent living in those other countries, like particularly this study was in Canada, were actually less susceptible than people that did not. So there may be a genetic kind of thing going on. Regardless, I could probably do a whole episode on this, but I'm not gonna. I'm just gonna talk about what to do about it, right? So what are the treatments? Any antidepressant would be the treatment. Big surprise, right? Just the standard thing. However, bupropion is the only FDA-approved treatment specifically for seasonal affective disorder. Bupropion is often a first-line medication for me. I see this, I'm probably going to go with bupropion first, unless I have reason not to. All right. Another thing that you can consider is that they don't need the treatment necessarily year round, right? So you could taper if the antidepressant's working and they want to, you could taper it off at the end of the season and then start tapering it, or start it back on prior to around the time that the symptoms are going to come back. So the patient may prefer to be on this for half the year and not on it half the year. Some may prefer to be on it all year, and that's going to be up to you and the patient. But this would be one disorder where you would kind of have that as an option. All right. Another treatment you could consider is bright light therapy. Okay. I'm going to talk a little bit about this at the end when I talk about ECT and kind of some of those like procedural things, but I want to bring it up now. So bright light therapy, typically we're looking at 10,000 lux. Lux is a measure of light for 30 minutes in the morning. And there are light boxes that produce this. If you're going to recommend this to a patient, now insurance is probably not going to pay for it, but they're not expensive. I mean, I think $100 or $200 or something like that. I haven't checked recently. That's what I remember. But you're going to want to make sure that it's at least 10,000 lux, because less than that's really hardly anything at all. And now going outside would really be preferable. So a bright day actually has 100,000 lux, a cloudy day 25,000, and a really overcast day 10,000. So even though it looks dark outside, inside lighting is about 250. The moon is 1 lux, but indoor lighting is nothing. Even a super overcast day, even though it may feel darker than it is inside, that sunlight is really strong. You're still getting 10,000 lux. So if the patient can go for a walk in the morning or go outside, now just like coming through the window can decrease by the light by up to 50-fold. So let's do some math. We got a bright day, 100,000 lux. Let's divide that by 50. That's 2,000 lux. So your lux is dropped from, and this is the best conditions, 100,000 down to 2,000, right? And 2,000 is not enough. So just having a bright light shining through the window may help, right? It might, but if you're doing bright light therapy and you're trying to treat this, the 2,000 is probably not going to be enough. So they either need to go outside or use the light box if we're going to try this treatment. Okay. And there's some things that you need to know about the light box. Don't look directly into it, but you need your eyes open. Remember, circadian, you've got I can't remember off the top of my head. It's a part of the brain that's connected to the optic nerve. It's like optic, something or other. It's involved in circadian rhythm. Like we want that to be activated. So we want the eyes open, but we don't want to look directly in the light because we don't want to hurt our eyes. They can read or watch TV or do whatever while this thing is shining on them. And we want at least 30 minutes. Some suggest 45 to 60 minutes, but there's no comparative studies, but we do want at least 30 minutes. So this is a treatment. And the thing is, this treatment can also be used for just depression. That's why I'm going to talk at the end of the depression series, but specifically for seasonal affective disorder, it might be, something higher on the list. It also may be something attractive to the patients because they're like, oh, this will have less side effects and it's not a medication and I don't want to take medication. So that this may be something that they actually like. So there's evidence this could be helpful. I think going outside is a better option, but like say we're in a place where even though very overcast is 10,000 lux, it's wintertime and we're in Alaska and the sun's not coming up until 1 o'clock in the afternoon, and it's going down an hour or two later. That's not going to work for us. All right, if we're in Texas where I'm from, this is probably not going to be a problem. We got good sunlight year round, even if it's overcast, right? But the patient may not want to go outside. They've just woken up. They're having a hard time getting out of bed. They want to have their morning coffee and their morning routine. Maybe some people like the idea in the morning of going out on the chair and reading a book or whatever, kind of starting their day with in the old days newspaper, but now maybe their phone, reading through whatever, having their coffee. And if that's the kind of person that wants to do that, awesome. If they're the kind of person that doesn't want to do that, the light box may be a good alternative. But you want to make sure you're getting one with 10,000 lux. Okay. Some other options other than bright therapy. So dawn stimulation is another one we can use. This is also a device, and I guess you time it. I've never seen one of these. I just read about it before I prepared this lecture, so I don't know much about dawn stimulation. Dawn meaning the beginning of the day. It's a machine that makes gradual room light brightening in the morning, but just to the regular 250 lux. But it starts like I think 60 and 90 minutes before wake up time. So essentially, we don't have the sunlight coming through the window because we're in a latitude or a daylight savings time situation or whatever, where that's just not happening. And so we want to use this light to kind of simulate the natural light that they would have seen during, because remember, these folks are fine the rest of the year. All right. And I don't think I mentioned it before I talked about treatments, but these are recurrent episodes of major depression, mania, or hypomania with seasonal onset and remission. So they come on with the season and then they go. They don't stay around all the time. And that's another thing I never seen and never thought about, was that this could also apply to mania and hypomania symptoms. Maybe something I should keep in mind, because people that have manic episodes typically only have a couple a year. Perhaps they're happening in the seasons. I don't know. The treatment there may be different. So that's dawn stimulation. ECT, if the standard treatments don't work, ECT could certainly be tried for this. And then just a tiny word about the summer type. I often joke with people, and maybe a little bit serious, that I have the summer type. I'm a weirdo. I don't really like sunlight. I like the rain. I like the mistiness. I'm not from Seattle, but like I'm very at home in like a Seattle, London type of climate, the type of climate that everyone else hates. I'm a night owl. I love the dark. I hate heat. I hate, bright sunlight. I don't like going to the beach. Right. So, and whenever the weather is to my liking and I walk outside into that cool, misty, I don't know, darkness, which unfortunately I live in a subtropical island, so it's not the weather that I'm getting here. But we do get it occasionally in the winter. I feel better. And then when it's like a bright, sunny, hot day, I feel worse. And so I don't know, summer type, it's not common. I don't even know if what I described to you would be a summer type. But there were a couple suggestions that I saw for summer type, and that would be limiting light exposure to less than 13 hours a day, and using air conditioner, very cool, especially at night when you're trying to sleep. There's some other things you could consider: sleep hygiene, walks outside, I already mentioned, and that's to get those luxes. Yeah, exercise and indoor lighting. So making sure we have adequate lighting indoors. And then a couple of things notably not on there are melatonin and vitamin D, because you're probably thinking, wait, those might help. Vitamin D, I'm going to talk about it a little bit later on. There's not very much evidence that vitamin D helps even with a vitamin D deficiency. You may have a patient that, like, there's not a lot of sunlight, their vitamin D goes down. You treat it with vitamin D. That's not going to help the seasonal affective disorder. I don't buy into vitamin D unless it's like severely deficient as helpful. I've never given a patient vitamin D that had a mood problem and they got better, ever. And for that reason, I rarely give it. But a lot of other people do, like primary care. So I've seen a lot of patients that are on vitamin D, and I've never seen one that got better. It's just not that effective. So we'll talk a little bit more about vitamin D and, when to treat that, why to treat it. But that's going to wrap up the subtypes. We covered a lot of stuff. There's a lot of subtypes of major depressive disorder. And I think the key thing to remember is that the treatments we talked about, for the most part, other than the bright light therapy, which we haven't talked about yet, and ECT, which I've mentioned but haven't talked about yet, these are all things we've already talked about. These are all meds that you're familiar with. Most of these we talked about in the augmentation lecture. However, you might want to move some of those a little bit higher in your algorithm, depending on how the symptoms present. If you get one of these subtype presentations, maybe MAOi goes a little higher. Maybe lithium's on the list. Maybe the antipsychotic pops up a little bit higher on the list, or maybe it's at the top of the list. Okay. So that's where knowing like these differences can make a difference, because you might have eventually got to that treatment way down the line. But hey, maybe the patient doesn't last that long. Maybe they don't stick with you long enough for that. So we want to make sure we're giving them the best treatment as soon as possible, getting them, because they want to get better today. That's not going to happen. At best, it's going to be a couple months. But if we're talking about fourth, fifth line, I mean, it may be a year. They don't have that long. So let's really take a real thought into these subtypes and consider that maybe TCA should be a little bit higher, depending, if they've got the subtype that suggests it, right? Maybe something that you weren't going to use. And maybe I've enlivened you. You're like, you listen to the MAOi lecture, you listen to the TCA lecture, you listen to the augmentation lecture, and you're like, hey, I'm actually going to use these, but it's still super low on your list. Hey, here's a time where you might want to pop it up a little bit higher. All right. So I want to thank you so much for joining me. Right. And please, your ratings and your reviews, this is what really helps me. Like, I've been telling my friends that I've suggested the podcast to, I'm like, please rate it, because if you really like it, it takes 2 seconds to rate it. If you have time to leave a comment, that would be awesome. But that's what helps the podcast show up in search results. And so that there's people out there that are wanting to get this information, that want this information, so that when they do the search, this podcast is going to pop up high on the list, and they're going to get to find out about it. And then we get a bigger audience, and then more people have access to this information. So, I'm not doing this for me. I'm doing this for educational purposes. I'm not profiting. I'm doing it for educational purposes. I'm doing this to help patients. And the only way we get this word out to patients is if people can find it. And the way they find it is if you tell them, if you rate it, if you leave reviews that they read and they're like, oh man, that sounds great, I want to try it too. And if they don't like it, fine. Not everything's for everyone, but I at least want the people that would want to have this information be able to get it. And like, you guys that are listening right now, you're the ones that can help me. So like, at a bare minimum, just go down on the podcast feed where you did this and just pop, the rating on there that you think I deserve. Hopefully that's 5 stars. But I want to thank you so much for listening. I hope you'll tune in next time. I'm going to go over pediatrics and geriatrics, and how treating depression are different in those two populations. And then we're going to go into a series on reproductive, so female mental health. That, I know I'm not a female, but I've done so much research on this, and I've put a lot of effort into this. And especially for you female providers out there that you may have patients that are more comfortable seeing you than me, you're going to want this information. So we're going to hit some subgroups next, kids and seniors. So I will see you next time.